Dr. Teble, over to you. Please start.
Okay. Yeah, thank you very much, Amarachi and Mohammed. Thank you very much. Dear colleague, ladies and gentlemen, and panelists as well, welcome. And good afternoon to all of you, and welcome again to join this webinar. It is a series of webinars on mpox, monkeypox. This is the session number three, and it is about the standard case management, prevention, and control of mpox. And this is a key component of the control for mpox and any other disease as well, because you can have good surveillance system, good diagnostic system, and better understanding of disease. But if you cannot manage cases, and it will be very hard to play a role in prevention and even control. That's the key, because trust comes with management of cases, whether it is the clinical cases, or whether it is even asymptomatic cases, to convince them not to spread disease. It is important to have the ability and system in place to do the case management. That's today, a series of webinars will be about that with eminent speakers, presenter, international presenter. You will see how they will cover the topic, and you can go and apply the skills and knowledge you will learn today from this webinar and on OpenWHO platform, as well as other resources available on different platforms around the world. Welcome again. And today's agenda, we will cover, as usual, and the topic we covered last session, and where you can get that information in case you miss the presentation. And because this is transparency in terms of knowledge, and share the knowledge as a part of capacity building, so you will have a chance to liaise with our colleagues. They will share those presentations in PDF format and the link to the record as well. And we will cover the methodology and the best practice when you connect to the webinar, and in practice as well, even on the ground, how you need to address a health emergency. Today, we will cover the clinical symptom, complication, how you're going to address it, a differential diagnosis and treatment, and the various therapeutic means. And that will be done with Dr. Rashidatu Fua Kamara and Professor Ogena Dimi, a well-known figure in international really arena today in terms of mpox clinical case management. It is not only in pox, but they do other diseases. And you can liaise with them even independently for consultation. They will be welcome. They will welcome you. So that's part of capacity building, to create that network. So you can have that large network, good contact when you face clinical, when you face challenge, or you face disease of etiology. Even you can ask them, they can share their experience, and they can even serve as a coach. Whether you want to do your PhD, you want to do any type of advanced study, you can share information with them. Then the next topic will be the prevention and control strategy. Among those prevention methodology, you have the vaccination, an important tool, and how you need to protect yourself, protect the staff, protect the family member, even for prevention, to prevent further spread. And you will heard a little bit, you will hear about the contact tracing as well, which was covered last session. We will just give you that briefing with Dr. Brian Ejong, who is on the ground now. If I don't make a mistake, he was on the ground in the DRC. Then Dr. Deborah Barasa as well will speak about, it is kind of joint presentation, both session, interactive session, are joint collaborative work. So that is That's the richness of it. As agenda, as you all know, what we covered last time, it was with Dr. Daniel Ebezener, who recap. He is not here today. He apologized, but he asked us to do that on his behalf. And it is always exciting, to have him on board. Probably he's connected. He can step in at any time. And myself, I will introduce the methodology, and I work in the health emergency preparedness and response department cluster. I do work with various clusters within WHO as well, whether it is in the African region or elsewhere, the other region. Now, last session, about surveillance and reporting and how to establish effective surveillance system and reporting mechanism. This session, last session, was covered by Dr. Felix Sani and Dr. Thomas New Nagbe, and they outlined the principle, the best practice in surveillance. And we did have a feedback how to integrate animal component, the surveillance component in the case investigation form, and it's done, but the colleague will review the investigation form so that can be integrated, and that will really bring sectors again together so they can have information, timely information, and to share that one together. So that's very important, and the different researchers in the countries, how they can be involved even in terms of epidemiological investigation using advanced methodology, case control study, cohort study. You can name all these best design study which will strengthen the surveillance. Now, including community-based surveillance, participatory disease outbreak detection, and so outbreak detection, disease detection, you can name it as you would like. Now, the section 5 from last session was covered by Dr. Elise and Mrs. Rachel Achila. They covered the diagnosis and laboratory testing system, the different technology used for mpox. You have seen that, the real-time PCR, very sensitive, and rapid test. They talk about it, and there is a challenge, but colleagues are working with different manufacturers to improve that diagnostic test, that it can be used on the ground. And some can be used now. There's nothing wrong with it. It is really just it can be used to support the surveillance, the control mechanism put in place, and to control outbreak as well. We had a question and answer session. These are available again, and panelists address all these questions. We talk about vaccination. The companies and partners need to work together if we want to really to control this disease at the source. So all sectors should be involved in for disease control. And for this session, as we say, you have our panelists and Dr. Rashida too, who is an infectious disease and case management expert. She worked with us during COVID and during various, even dengue fever, and now she's working on, she worked on the mpox as well in the past. And you have a Professor Ogena, Dimi Ogena, and he's an infectious disease physician, well known. He was at the International Health Regulation Committee as well in terms of the public health emergency declaration. Is a member of the group and is well known. It contribute very much deeply in it. I saw it. I was on I was connected as well, and is well known. He even presented during EQUAS. That's a West African Health Organization webinar. He provided an excellent presentation. We always consult him and to come on the panel, whether it is on new journalists, to speak with journalists, with our regional director. He took part in it. And we have Dr. Brian Ajong, who is a public health officer and a specialist in mpox response. Recently, he was deployed. As I said at the beginning, he was on the ground. I'm not I don't know if he left already, but he will, when he does his presentation, he will tell us where he is based actually. If he is in the DRC always, and he can, DRC, he can mention that one. Now we have Dr. Deborah as well, Barasa, who is a infectious disease prevention and control specialist. She is with us today. They will really outline well what strategies and what methodology really you need to use for mpox. And not only for mpox, but the methodology or it can be applied to other, the approach can be applied to other disease. But we will focus on mpox. Now, as a best practice, and as for this webinar and other webinars, as the previous one, we spoke about what we would recommend and what we strongly recommend. And this is a very important issue, and to avoid really misbehavior or to respect the code of conduct, to prevent any type of harassment, and whether it is sexual or physical or verbal, we need to adhere to the code of conduct. Most of our response activities, if we don't respect the code of practice, it can lead to really a disaster. The reason I'm saying that, you can lose your job, you can lose trust, you can jeopardize the entire institution. And that is applying not only to WHO, but to all UN systems, and even at the country level. And I think we, in our system, even at the country level, there is a code of conduct. Yeah, any society, there is a good code of conduct system. Now, when it comes to use the different icons, because the people you connect at a different time, and it is very good to respect and to follow the instruction as well. This is not the first series of webinar. We have a different, and we keep saying it. And please use the icon, which is question and answer. It is abbreviating here. Please use this one just to give your question, and you will get the answer here. And so that's very important, because it makes it easy for panelists to follow rather than using the chat. The chat is for IT, information technology, and logistic issue. In turn, for example, you cannot hear the interpreter. You can mention that one. Otherwise, we cannot solve your IT problem at your level, but we can solve if we have panelists have a problem to present. You cannot see it. You can ask those kind of questions in the chat. All material will be shared. We will come to that one. Now, we will move to the next here, and you will see that on the globe. You can see this globe here. I point on it. That's called interpretation globe. Sometimes we hear from participants, no, I cannot see the interpretation. It is written clearly in English, and I think that's enough to read, interpretation. But when you get into the interpretation, you click, you have this off. If you understand both language, fine, that's a bonus. Otherwise, you click on English or you click on French. And you can see that there is no Portuguese, but for whatever, if you have a question in Portuguese, please give, and we will address it. And you have an interpreter who can take that one. We have a people expert who can speak Portuguese, Spanish, any language, name it. And we will try to address your question. Yeah, okay. Now, And below, there is a note in the book that's written. The interpretation of proceedings serves to facilitate communication and does not constitute an authentic or verbatim record of the proceeding. Only the original speech is authentic. That is to cover everyone legally. So you don't go and take anyone to the court because the interpretation was not good. And artificial intelligence does now. And so now, if you want to see the caption, that means the transcript of whatever been saying, you can click on the CC here, copy of that here, this sign. You can click on here, you will see it on your screen. We will not see it, but you will see it. You want copy it, if you can copy and paste it, if it doesn't help you, but we strongly recommend to follow the presentation. I think that's beneficial because that's where you capture from that. It can serve you and you can interact as well during question and answer time. You can hide it if you want to hide it. Yeah. Okay. Now, this is general rule. And for those who would like to raise their hand to put the video and speak, you can all note that they will be recorded. Whatever we're gonna say here, it will be recorded. Then the material and any feedback will be shared, and they will serve you to improve our capacity as well and to correct our mistake. So, and it is 3 bullet points. The session will be recorded. So, and you need to give your consent in case you don't agree, then you can mention it. You will not be recorded. We will do our best to respect the privacy. If you want to put your video, then we can stop the record at that time. But preferable, we prefer to record because we will share it. People can learn from what we say here, and whether it is mistake, it is well done or not, and that's part of it. And so all material, including a record and PDF format, will be shared. It will be done by email, professional email. You will receive your individualized email message. And we have a team expert who will do that for you. And you won't receive a bulk of email to all. So you can focus on it, but please download it as soon as possible because the link will expire. Then you need to write again to the sender to get it. Okay. As we continue to improve our training program, your feedback is invaluable to us. Please, you will receive the question, survey question. That's important. Be transparent, be fair, and just note it. Things you like, things you don't like, what can be improved. It's very hard to please everyone, but at least statistically, we always aim to achieve the best. Now I will stop here and we will move to our presenter and really welcome again. And the first, you will see who will do that. The first speaker, we will go to our colleague, and then we can move on to the next speaker. I just clicked, so you know how these are here. And so the speakers are here, Dr. Rashidatu Kamara and Professor Ogena Dimi. They will present the first part of this session, which is session 6, recognizing mpox clinical symptom, complication, differential diagnosis, and treatment therapeutic as well. Over to you, Dr. Fuad Rashidatu and Dr. Dimi Ogena. Thank you. Over to you.
Dr. Rashidatu, you are muted.
Thank you, and good day, everyone. I need not introduce myself again, as Dr. Chible has done an excellent job. I think we'll just move straight into the presentation. Today we'll be talking about identifying the clinical symptoms of monkeypox, looking at differential diagnosis, and then the second part, which is on treatment and therapeutics, will be taken by Professor Dimi Oguna. So I'm pretty sure some of us have been following the previous sessions, but for those of us joining in only today, this is just a brief introduction. Monkeypox came into, let me use the word prominence, just 2 years back in 2022, when it was declared a public health emergency of international concern. Prior to that, monkeypox, we have been having outbreaks of monkeypox, but then it was not that global. But then since July 2022, we've seen a monkeypox in most of our regions. It is a zoonotic disease. The natural reservoir still remains unknown. However, the virus was first extracted from a disease squirrel, the Phoniscius anerythros, which was the first report of monkeypox virus being isolated from a wild animal. It belongs to the Poxvidae genus from the Orthopoxvidae family, and it is one of the 4 major orthopox viruses. The 3 others being the variola major virus, which causes smallpox. Thankfully, that has been eradicated. The variola minor virus and the cowpox virus. We currently have 2 genetic clades, the Congo Basin clade, which is also referred to as the clade 1. And as the name implies, it is mostly found in the central region of Africa. And we also have the West Africa clade, otherwise known as the clade 2. And it also implies it is mostly found in West Africa. The latter is actually less severe after infection. In 2022, during the outbreak in Nigeria, in 2017, there was a new lineage, the B1, which was seen in Nigeria, and that has been referred to or classified as the clade 2B. I think I've said this. Initially, we were seeing monkeypox only in West Africa, or the West Central Africa. But since 2022 to 2023, we actually saw it all over, but now we are seeing mpox mainly in DRC. Reservoirs include rodents, squirrels, and giant poached rats, and also monkeys, and humans and monkeys are the disease host. Let us be mindful of the fact that the large number of cases that are diagnosed with monkeypox are male, especially in men having sex with men, particularly in Canada, Spain, and the United Kingdom. So what we are seeing, it's a different transmission route, that sexuality could be another form of transmission with close contact. And we're seeing most of these cases in younger people, less than 40 years of age, and the median is between 30 to 31 years or 30 to 35 years. The median is actually 31 years. And this actually brings to light the fact that these are the population that were born after the discontinuation of the smallpox vaccine. And this may reflect a lack of cross-protective immunity. It is mainly transmitted through the skin or via respiration, inhalation. So transmission could occur via direct contact, vertical transmission, percutaneous, or indirectly by fomite or inhalation, as I had already mentioned. We can also see transmission from animals to humans, which could be by direct contact, humans having direct contact with animals, especially those that are infected, or through accidental scratching or biting from these animals eating meat that are infected, and also when they come in contact with contaminated objects. Person-to-person transmission is also seen, and we have different areas. The contact forms open wounds, skin lesions, or the genitalia, when you have close contact face-to-face with the person, or when you have contact with bedding and clothing that are contaminated. Person-to-person contact also spread beyond immediate close contact, but then we need to understand that the case fatality rates are very low in monkeypox than those that were observed when people were being infected with smallpox. A direct contact has been the primary mode of transmission during the recent outbreak, that is the 2022 outbreak, but then we had also seen percutaneous transmission after people were reported having been having other needle stick injuries. And some studies do say that semen is unlikely, despite we are seeing most of them being sexually transmitted. But then because of the low viral load in semen, the risk of exposure through semen is also low. However, we need to take note of that if a person infected has open wound or lesions, then definitely the risk is very, very high. Vertical transmission also can occur from mother to child, and we have seen the human-to-human transmission that led to outbreaks. So this is just a pictorial view of what I'd already said. I did mention that we can have transmission through skin and also through respiratory droplets. And from the skin, you can have your local replication, and then you'll have the primary lesions, which you could have localized rash, or you can have some little replication in the lymphatic system, and then you can have a mild viremia, and you can also have mild rash. But then if the application is extensive, you can have the generalized rash all over from your face, all over your body. The same also applies if you have inhalation, you inhale these droplets, you can have viremia, and if it's extensive, the application is extensive, then you can also have generalized rash. The incubation period is between 5 to 17 days. Other schools of thought say between 5 to 21 days. And the monkeypox disease can be divided into two phases. During the incubation phase, while you're having your application, the person is not contagious. However, when we have the two phases, that is the prodrome and the rash phase, let us be mindful of the fact that that person becomes very contagious. So the prodrome symptoms of monkeypox are headache, weakness, fever, chills. You will have sore throat and lymph nodes. And this usually lasts for a few days after the fever and the lymphadenopathy. And then the rash appears. The rash starts with the face and then appears on the whole body, and it is characterized. You can have just a few, like we've seen previously, depending on the extent of the replication, from a very few to several thousand lesions. And then as the rash progresses, about 2 to 4 weeks, you'll have the plaque, which will be replaced by the papules. This plaque could also be referred to as the macules. Those are flat lesions. And then you'd have your papules, you'd have blisters, and then pustules. And then you'd have scabs. Eventually, you'd have shedding, and then re-epithelialization of your skin. And in people with this infection, you could see the various stages of the rash. That is, you could see macules, you could see papules. You can see different forms of the rash at the same time. So this is just to illustrate what happens, the pathogenesis from you becoming in contact with an infected person or with an infected or contaminated object until the time you have your prodromal phase or your rash phase. When we think of the possibility of that person having mpox, we would also need to consider the likelihood of other diseases. So these are some of the differentials. We'll need to consider chickenpox, smallpox, although this is not so likely because of the eradication. We could also think of molluscum contagiosum. We could also think of measles, rickets infections, bacterial skin infection, anthrax, scabies, syphilis, other STIs, drug reactions, and also allergies. But in most of the cases, let us be also mindful that monkeypox, people with mpox could have co-infections. So the symptoms of monkeypox could last between 2 to 4 weeks. And in many of the cases, that's the good news, it is usually self-limiting. More than 90% of the cases could heal. But then a severe clinical course is associated with a longer period of viremia and viral shedding. And the lethality of monkeypox patients after infection also depend on the clade of the infected virus. I think I did mention the clade 1 and the clade 2, and the route of infection and also the age of the patient. Lethality of patients infected with the clade 1, that is the Central Africa clade of the virus, is generally higher. That is, you see a lot of mortality with this particular clade than that of the West African clade. Monkeypox also, depending on the age, is often fatal in children under 16 years. The clinical picture described for those that are unvaccinated is more severe, and then you can see vigorous and different forms of the rashes, and could also lead to higher mortality. The infectious period lasts from the onset of the clinical manifestations. I think I mentioned this again earlier, from the prodrome phase until the rash phase. And please note that until all the skin lesions have scabed off and reepithelialization has occurred. So when a person becomes infected and the features can be seen, you need to stay away from that person until you can see that the skin is building back, is coming back on. There are a few complications which could lead to death, and these include encephalitis, keratitis, pneumonitis, and also secondary bacterial infections, especially from the exposed wounds. So we have various lesions of monkeypox, and let me draw your attention to the Atlas of Monkeypox that was put together by the WHO. I think in the previous, in the subsequent slides, you'll see the website wherein you can access this atlas. So we have 3 stages of these lesions. They are the early lesions, the progressive lesions, and the late stage. The early lesions are typically 1 to 3 millimeters in diameter. They appear solid. They could be macules, papules, vesicles, pustules, or even false pustules, pseudopustules. And then we have lesions that are progressive. And when you look at these lesions, what you'll see like they are umbilicated. They have this dot in the middle. They could be donut shaped. And then they could have this crust that could develop in the donut or the umbilicated central area of these lesions. And then at the late stage, you see erosions and ulcers, which may also develop. And then you'll see the superficial loss of the dermis, or you could have a complete full thickness loss of the dermis. We'll be showing you some images. Please, these are discretional. Kindly be advised. So the active lesions, there are 3 morphological types. You'll see the ulcerations or erosions without surrounding induration, and then you see the papules and nodules, which in most cases resemble chancre, which are actual syphilitic lesions. And then you see some that are sloughy. They look like the sloughing of the pseudomembrane, and that they could also mimic. You could look at them and think the first thing maybe you might think of is candida infections. All these lesions heal fast without crust formation or dyspigmentation. So these are some of the images. On my left is an ulcer with purulent base. As clinicians, when we look at this, we can think of chancre, we can think of chancroid, we can think of herpetic lesions. These are things that we need to consider, and we'll talk in brief about differentiating or coming to conclusion on your diagnosis. And then the umbilicated pseudopustules, the donut shape. This is a typical image of this. And on my right, you'll see the pseudopustules on the arm. And then we'll also have the crusted or the scaped lesions. And these are, like I had earlier said, also they are evolving lesions, and they may develop at the surface. And they could be present as yellow serous crust, or they could be bleeding, or they could form an eschar. The crusted lesions are considered infectious until underlying lesion has completely resolved. This is something I'm repeating again. So when you see them being healed, you need to ensure that until the crust has been replaced by a full layer of the skin of the epidermis, that person remains infectious. So this is another showing the scaped lesions and the eschar. You'll see the eschar on my left, and then on the upper lip. This could also be mistaken for herpetic lesions. We know that herpetic lesions are mostly seen around the lips, the tongue, etc. And then when the lesions are resolved and healed, then they are no longer raised. You see that the epidermis has started to form or has been formed completely, and any underlying erosion or ulcer has been completely healed. So this is it. After the inflammation, you see pink scars, and then you'd see that depressed scar on the head of the penis, and then you'd see on the arm, on my right, the re-epithelialized lesion with surrounding collarate of scale right there. We can also see other clinical features, especially in the eyes and the skin. These are pictorial views of what you could see with mpox. Looking at the eyes, you can mistake them for conjunctivitis. And on my right, you see people presenting with exanthem. These are also different stages of the rash. You see on my right, you see the top right, you see the macular papular vesicular lesions. So like I mentioned again earlier, these lesions could present in different stages. So seeing the forehead of this person, there are various stages of these lesions. And also on my left, the bottom left, you could see the various stages of the lesions. And this is a typical example again of the various stages of the lesions. You can see scab, you can see the pustules, you can see papules, vesicles, etc. on the face, and also the chest, the arms as well. And then also these are the lesions again on the feet. So they can start from the face and extend downwards all over your body. The same here. You can have them on the armpits, all over your body. You could have your lesions, different sizes and types of lesions. So I'm looking at differentiating monkeypox from smallpox and chickenpox. Thankfully, we are not seeing cases of smallpox again, but then monkeypox is clinically milder than smallpox, although they have similar presentations. Mpox also presents with less mortality and scarification, but then with monkeypox, you have enlarged lymph nodes, and that is something we need to think about again when we are looking at other STIs. And then for severe chickenpox, you'll see that even the progression of the lesions are different. For chickenpox, you'd have them in the palms and the soles. Be mindful that monkeypox starts from your face and downwards. And then the lesions in chickenpox are more superficial. Monkeypox, they are deep-seated, and that of chickenpox, they occur in clusters, and they are mostly in the same or at the same stage. With mpox, you can have varying stages of monkeypox. Now, for the STIs, just in brief, you look at most the common STIs that they could mimic would be syphilis, the chancre, but then monkeypox lesions are painful, but then chancre, they are usually painless, and then they don't occur in groups or clusters. They could only occur, mainly occur, sorry, in as single lesions. And then chancroid, H. ducreyi, they're also painful. I think for me personally, it's difficult to differentiate mpox and chancroid because they have similar presentations. So you need to test. Testing is very crucial. And the last session we had, the discussions were centered around testing for monkeypox. Be mindful that these could also occur together. So you need to distinguish. So they are both deep-seated, they are rubbery, they have lymph nodes, they are painful. But then with chancroid, you know, the borders are really ragged, they really look dirty, and they are surrounded by round redness, the erythema. And then for herpetic lesions, they occur on the tongues and lips, but then they can be seen around the genitalia also. They can be seen as bumps, blisters, or ulcers, either around the anus or genitals, and they're also painful. Lymph nodes are usually found in all of them, but then most of them do have regional lymph nodes. That is the inguinal. Monkeypox should have lymph nodes all over, so you need to look at that as well. So I think this is my last slide, and I would like to hand over to Professor Dimi Oguna to talk about the treatment options that we do have for mpox. Let me hand over now to Professor Dimi, who is a professor of medicine and infectious diseases from Niger Delta University of the Teaching Hospital. Over to you, Professor Dimi.
Yeah, thank you very much, Dr. Rashidatu, and good day to everybody. So my first slide is intended to tell us that in the treatment and the management of mpox, we need to consider the natural history, the spectrum of presentation from the time of exposure to the time where patients develop sequelae, reinfection, relapse, in considering the management and treatment of mpox cases. So what I have here is just a chart that gives an overview of the chronology of symptoms and signs and complications and the sequelae that occurs following exposure to mpox. I believe this is self-explanatory. It just says that following exposure, a patient can either develop a symptomatic or asymptomatic disease. For a symptomatic disease, there are three categories, about, should I say, four categories. It could be mild, it could be moderate, it could be severe, it could also result to a fatality. Usually, a percentage of patients, 50 to 70% of patients, depends on the source of exposure, may develop what we call prodromal symptoms. And I've listed some of the prodromal symptoms here, which include symptoms that we're very familiar with, that is common for most other infectious diseases. Following a period of prodromal symptoms, the patient develops a skin rash, which we call the eruptive phase, eruptive stage of the disease. And of course, it could be a rash in the skin, on the skin or the mucosal surfaces. And there are varied distribution of the skin rash, some of which has been discussed by Rashidatu. Some patients may progress to complications, and I've listed some of the complications, and I think Rashidatu has also discussed some of the complications that may occur following mpox. Then we have sequelae. Then in some patients, of course, we could have a relapse or reinfection. This just to give us an overview and to tell us that if we want to care for monkeypox patients, we must consider this chronology of presentation that happens in a natural history of mpox. Next slide. Next slide. All right, so there are several components in the management of mpox cases. I have just listed 7 main components here in the management of cases with mpox. Very, very important is the care of skin and mucosal lesions or rashes. Then there is psychological support, there's counseling, there's supportive medical care. Of course, there's a role of specific therapeutics, which we will discuss in details as we proceed with this presentation. There's treatment of complications, and there's nutritional support. Next slide. Just for emphasis, this just juxtapose the various components of treatments and the natural history of mpox. I have initially explained that monkeypox or mpox follows the natural history to the point where you could have a short-term and long-term sequelae. And if you want to comprehensively manage a patient with mpox, you must start from the time of exposure. And usually, as depicted in this diagram here, you notice that counseling and psychological support is expected to start even at the point of exposure. Supportive care, nutritional support, treatment of complications, care of skin and compromised mucosal surfaces will follow according to the period in which those symptoms emanate. But this is just to emphasize that the care of mpox patient is not necessarily about treating symptoms alone. Active symptoms is also looking at the patient before they develop symptoms. And what I'm going to do is to give an overview and some details of these various components that have been listed here. Next slide. So there's a clinical care pathway that we are very familiar for all disease conditions, not only infectious disease. And the idea here is that if a patient with mpox presents to you in your clinical setting, what do you do? What is the clinical care pathway that you expected to follow? The first thing we usually do is to screen this case. So the purpose of screening is to identify whether that case is the suspected case. Of course, we use our case definition. And I believe there has been a detailed discussion on the case definition of mpox in prior webinars. So if we believe the patient is a suspected case, it behoves on us to confirm that case. So the next step in this clinical care pathway is to carry on a diagnostic testing, which of course is PCR. And while that process is ongoing, for every suspected case, we need to triage and do a clinical assessment of that case. If we're ultimately able to confirm the case as a confirmed case, we need to decide how that patient is going to be cared for. And generally 2 ways the patient can be cared for. The patient can be cared for at home or in the hospital. And there are several reasons why you want to care for a patient at home or in the hospital. Most cases of mild disease are usually cared for at home. And that's what we do routinely. Of course, there are similar things that you need to take into consideration that we'll discuss in the subsequent slides. Hospital care is usually recommended for severe cases, moderate to severe cases, especially when you want to manage complications of mpox. We should also note that people are also hospitalized for public health reasons, just for isolation, just to prevent person-to-person transmission, especially in the setting of an outbreak when you want to break transmission chains. When a patient is cared for and recover, of course, you need to follow up the patient. Of course, we know that the natural history of mpox lasts on the average of 2 to 4 weeks. And what that means is that patients are expected to recover 2 to 4 weeks after the onset of their symptoms. It varies from one patient to the other, and it might even be longer for patients that have complications. So you follow up the patient that you may want to discharge the patient from care. As we continue to gather more information about this disease, because there are so many things we don't know about mpox in terms of the long-term complications of mpox, and some have recommended that we may need to follow up our mpox patients for a longer period than perhaps the first 3 months after they are discharged from the hospital. Next slide. So let me talk about some of the components. Counseling and psychological support. This is very, very important. The reason for that is that mpox is a disfiguring disease. It's a source of stigma. It also results in anxiety, fears, myths, and misconception. We have reasons where patients have developed several psychological abnormalities. In fact, in my hospital, for instance, in 2017, a patient committed suicide on account of mpox. So counseling and psychological support is very critical and very important. And it's important that the patient is counseled about the disease. They need to know what the disease is so that you help to address the problem of myths and misconception. You need to talk about infection prevention and control. You need to talk about how you want to treat the patient, what you expect the outcome of that disease will be, and what you expect the recovery. And this is one has to be deliberate about this, because we don't counsel our patients sufficiently. That results in some of these myths, misconceptions, and some of the psychological challenges they face. So it's important routinely to evaluate the psychological state of the patient. And there are two things that the patient can experience that have mpox. They could be anxious, they could be afraid, and they could also be depressed. And we routinely recommend that every patient with mpox should be psychologically evaluated to determine whether they have anxiety disorder or they have depression, and we can then address accordingly. It's important that we engage mental and social health expertise very early, because the care of a mpox patient is a comprehensive process that involves multiple disciplines. And what we do from my prior experience is to ensure that especially in the setting of outbreak, you get social workers and mental health experts to provide such counseling and psychological support. Next slide. Supportive medical care, perhaps you say the mainstay of treatment of mpox, because ultimately, as you will get to see, we don't have sufficient evidence for specific antiviral treatment. So most mpox patients will do well with supportive medical care. As Rashida just said earlier on, mpox is largely a self-limiting illness. What that means is that in most cases with supportive care, they recover within 2 to 4 weeks after onset of symptoms. But there are certain symptoms and signs that we need to manage in order to alleviate or reduce the symptoms and the distress the patients face. Fever is a common manifestation in mpox cases, especially cases that we have seen in Africa. It's less common in the clade 2B associated with sexual transmission, but it also occurs, especially when they have complications. And we are all very familiar with the management of fever, antipyretics, tepid when required. Paracetamol is a recommended drug for treatment of fever, and the doses are listed here, which I believe we are all familiar with. One common manifestation of mpox that we see commonly in our practice is patients have pruritus, a lot of itching. And it's a significant cause of discomfort. It's a cause of sleep disorders. And it's also a reason why people hate the disease. So it's important that we address this challenge. And these are some of the general measures that we have used. The idea of having a warm bath, it has a soothing feeling and may help to reduce that feeling of pruritus. Of course, calamine lotions can be used. Antihistamines are recommended for people that have pruritus, and the dose schedule is listed here. Pain is a significant finding in mpox. And as Rashida said, most of the lesions are actually painful. I'm yet to see an mpox lesion that did not present with some form of pain, from mild to severe pain. And there are several options that are available here. You could use a paracetamol, non-steroidal anti-inflammatory drugs. Then you can step up the pain options that you have in terms of therapeutic regimens through tramadol and morphine. Again, the dosing schedule is listed here, and I believe this slides will be shared for us to have some details of this. Just a word of caution that some non-steroidal anti-inflammatory drugs should not be used for management of children on account of the expected complications that may arise, especially from the use of aspirin. Next slide, please. Nutritional support is also very, very important. Mpox cases have, especially when they have a lot of rash all over the body, they have rash in the mucosal surfaces, they have sore throat, they have difficulty eating. And some of them are also well dehydrated. So it's important that you assess the nutritional status of all your mpox cases. And if you have to assist them to take food, you need to do that, especially when they are very weak. There are situations where we have had the cost to pass the enteral nasogastric tube for our mpox cases because they do not have the ability to feed. And these considerations should be given to this. There are situations where you may need to consult a dietitian and nutrition, because nutrition is not only important for energy, it's important for recovery, especially recovery of skin and mucosal lesions. Next slide. Sorry, next slide. All right, thank you very much. Maybe my network is not very good. So
No,
just to confirm,
you-
are you still with me?
Yes, I am. Can you seek care of special populations? That's the next
Yes, I can
slide.
see that. Okay, yeah, that's great. Okay, thank you very much. So we now talk about scale of special populations. Of course, mpox is associated with what we call high-risk group, vulnerable groups, predisposed groups. These are groups that have a tendency of either exposure, severe disease, or they easily get infected. And it's important that we pay special attention to these groups so that we can address the problems that come with them. So neonatal infants and children, it's important that we monitor for potential congenital or perinatal exposure or infection. So if a mother, a pregnant woman has mpox, it is required that the clinicians managing such cases should closely monitor the infant, the neonate, over time. In fact, some are even recommending that we need to follow for a period of 2 years to be sure that there are no late onset congenital abnormalities associated with mpox. It is recommended that you give the child the usual immunizations and vaccinations as stipulated by your public health authorities. There is no demand to change your feeding practices. It's to be done on a case-by-case basis, so it depends on how the patient presents. So the clinician that is caring for the patient has the full responsibility to adjust care depending on how the patient presents. Pregnant women are also prone to mpox. Indeed, they have developed mpox, and some have developed all sorts of complications, including abortions and miscarriages and the likes. So it's important that we understand that we don't mpox, the prenatal delivery, antenatal and postnatal care is not different from what we do for somebody that is not mpox positive. What is most important is that you need to do some counseling and follow-up, educate the woman about vertical transmission, about complications, and also address anxiety because they are also very concerned about themselves, about their unborn children. People with HIV, of course, we are fully aware that, especially in the global 2022 outbreak, close to 30 to 50% of mpox cases have concomitant HIV infection, and those with advanced HIV are more likely to have severe manifestations and all more likely to die. So we need to prioritize the treatment of patients with HIV, especially those that have low CD4 count or advanced disease. But what is important is that if you also want to use antivirals, you will need to watch out for some drug-to-drug interactions between these antivirals and some of the antiretroviral drugs. Sexual active patients are also important special populations that need to be addressed because, of course, we know mpox is now a sexually transmitted disease and may be associated with other sexually transmitted disease. And so it is recommended that any patient that has mpox, especially where you suspect that that mpox is due to sexual contact and the patient has genital lesions, you should screen for other sexually transmitted disease. And it's also important that patients should abstain from sex until all lesions have healed. The WHO has recommended that before evidence becomes available, looking at the natural history of mpox, that to prevent transmission from the sexual route, from sexual fluids, that sexually active individuals are expected to use condom consistently during sexual activity for at least 12 weeks after recovery from mpox. Next slide. Yeah, so care of compromised skin and mucosal surfaces. Mpox is associated with a skin rash or skin lesion, a skin ulcer. I think Rashida had done justice to that. This just gives an overview of 2 patients that have lesions on the vulva, vagina, and on the scalp of skin. What is important about management of mpox is to ensure that you speed up healing because it can be very discomforting and disfiguring. And it's also a source of some of these psychological challenges that patients face. So you want to reduce discomfort and pain, and you want to prevent complications because skin lesions can become infected, there can be exfoliation, and there can be scarring if not treated early enough and if we don't prevent infection. Next slide. So the care of skin and mucosal lesions essentially involves keeping them clean with saline. You can use soap and water. You can use a mild disinfectant solution, and you leave open to air dry, except the patient has a deep-seated wound where you need to debride and then do a close dressing. You want to, as much as possible, address the challenge of pruritus. So advise the patients not to scratch. Most of the reasons why patients develop secondary bacterial infections is because they continually scratch their lesions. So you emphasize hand hygiene, and it is not recommended that you routinely use antibiotics. It's something we do because of several challenges that we have. It's not recommended except you strongly suspect a bacterial super infection. Of course, there will be erythema, there will be swelling, there will be significant pain, there will be persistent fever outside the prodromal period. Those are some of the reasons that you may want to suspect super infection, secondary bacterial infection. Oral source, you want some saline gargle, vitamin C, multivitamins. Of course, anogenital ulcers can be very distressful. That prior picture I showed of that young lady that had vaginal lesions that progressed to ulcers. She had one seed baths, and of course, she also has secondary bacterial infection, and which we'll discuss in the next slide. She also received antibacterial agents. It's important that you manage pain and other sexually transmitted infections for patients that have genital lesions. Next slide. So this just to give us an overview very quick of how we manage some of these complications of mpox. The major complications have been listed here: secondary bacterial infection, skin exfoliations, necrotizing skin tissue infection. Of course, that occurs in the setting of advanced HIV disease, pyomyositis, abscesses, keratitis, and there are other complications, of course, with Rashida has also discussed. It's important you clean the lesions when you suspect secondary bacterial infection. Then you consider antibiotics that are more likely to address the skin flora: fluoxacillin, amoxicillin, clavulanic acid, clindamycin, especially when you suspect some drug resistance that may make the other drugs not to be useful. Sometimes we even give metronidazole, depends on the risk of exposure the patient has. As much as possible, most of the infections are caused by streptococcus and staphylococcus, and you treat accordingly based on your local patterns in terms of pathogen patterns and drug susceptibility patterns. Skin exfoliation can be very severe. In fact, sometimes it may seem as if the patient has severe burns, and it's important you treat the patient as such. We have had situations where we had patient had extensive lesions, and with exfoliation that we had to consult the surgeons to ensure that patient was cared for appropriately. Necrotizing soft tissue infection requires immediate attention because most of these patients have very severe disease, and they may require debridement and surgical emergency. In most situations, it's a surgical emergency, and surgeons ought to be consulted so that they can intervene as soon as possible to prevent death. And we're just giving some examples here that some of these patients have necrosis, tissue destruction, and may have systemic toxicity. They have malodorous discharge, and they may have significant pain. And I've said it's common in patients with advanced HIV. Pyomyositis abscesses are common, and when you see an abscess, we have had several cases as such that have abscesses, and we have had cause to drain such abscesses. Keratitis, you require the consult of an ophthalmologist. Of course, there's a eye drop that has been useful in other viral infection, has also been recommended. In the absence of clinical efficacy trials, case reports have shown that this can be useful for some patients. And what is also important is to manage other complications depending on what you see. Secondary bacterial infection, pneumonia itself, broken pneumonia can be due to a secondary bacterial infection, can also be a consequence of the viral infection. It takes the clinician to determine whether it's due to a secondary bacterial infection or a consequence of the viral infection. Next slide. So let's now go to specific therapeutics for mpox. Just for emphasis to say that currently, although trials are ongoing, there is no concluded clinical efficacy trial that has shown effectiveness of any mpox therapeutics, specific antiviral agents But observational studies have suggested that there are some benefits. There are so many observational studies have been done and shown that within 78% of patients, okay, that's for vaccines, a number of patients will do better with mpox, especially people with advanced disease. It reduces the time to resolution of illnesses and the likes, but clinical efficacy trials have not been concluded. You should note that most of these mpox-related therapeutics were developed initially for smallpox, and it had to be redeployed for mpox because they belong to the same genus of viruses, and their presentations are somewhat similar. But in view of the lack of evidence of clinical efficacy, while we're waiting for conclusion of the ongoing trials, WHO recommends that when we want to use specific antivirals, we should use them under two situations. One is under randomized clinical trials, where we have the opportunity of collecting data, standardized data, so that we can generate evidence that will be of useful to us. When it's not possible for us to conduct clinical trials, it's recommended that we can use antivirals when available under what they call expanded access protocol or MIRI protocol. This monitored emergency use of unregistered and investigational intervention. And so that's the overall recommendation of the WHO. Of course, for several reasons, ethical reasons, the reasons to address pain and the rest, antivirals are being used for this emergency use authorization in many parts of the world, but not yet available in Africa, to the best of my knowledge. Next slide. So this is just to give an overview, not to give us too much details, so that we get our slides and we're very familiar with this. There are 4 main drugs that have been used clinically in observational studies for management of mpox cases. Not because clinical efficacy trials have shown that they are effective, but because they are drugs that have been used for other viral infections or for smallpox. And as such, they have been sort of redeployed to be used in cases of mpox. What we should be more familiar with is tecovirimat, which is a drug that is ongoing several clinical trials now. Then other antiviral drugs are cidofovir and brincidofovir, then Yersinia immunoglobulin. These are drugs that have been used in several cases, especially patients that have very severe disease in the management of these cases. But the emphasis here is that we have not yet concluded the clinical trials that are suggested that these drugs are effective. But as I said earlier on, some of the observational studies have shown that they could be effective. Next slide. So just to give us an overview, there's a number of ongoing trials, mpox trials. These trials are largely focused on the use of tecovirimat, the management of mpox cases. This is a last review, I think, early in 2024. So the number of cases perhaps have been updated for some of them, for instance, the PALM 007. So this just gives us an overview of the ongoing trials, the title of the study, the sponsor, the location of the trial, and whether the status of the trial, whether they're recruiting or they're not recruiting. If you look at it closely, you'll see the only trial that is currently recruiting in Africa is the PALM 007 that is currently ongoing in a region in the DRC, and is for clade 1. MOSA is another trial for Africa that is yet to start. I believe that with funding and other requirements, this trial will start. There are many other trials that are currently ongoing in Europe, parts of Europe and the United States of America and other countries, and you can see the overview. Emphasis, all these trials are focused on tecovirimat. Next slide. Again, what's the dosing schedule for most of these mpox therapeutics? This is just for your records. It's not for me to spell out every detail here. Just to give us the standard dosing regimen for some of these drugs, if you are given via oral or IV route. So whichever drug you are given, the dosing regimen is shown here. But it's also important to emphasize that cidofovir and brincidofovir, especially cidofovir, is associated with a number of side effects, renal toxicity and the like. So you need to give these drugs with some caution. and on a case-by-case basis. As a matter of fact, it is not recommended by all authorities, and you need to look at your national guidelines before you want to use some of these drugs to treat mpox cases. Next slide. So just to give us an overview that we have tecovirimat, which is the only drug that's been undergoing clinical efficacy trial as at now. And it is not wise that we are restricted to tecovirimat because ultimately we are already seeing resistance to this drug, especially in people that have advanced HIV and severe disease. And so it's important we have a whole range of drugs that we could have alternatives, especially in Africa, where we still have funding gaps. And tecovirimat is not readily affordable or even accessible to most African countries. And as I said earlier on, I'm not aware, apart from clinical trials, I don't think tecovirimat is available for routine care of patients in Africa yet. I know there are plans for it to be available, but I'm not aware. So these are drugs that have undergone preclinical trials. And this is a review that has been done by the WHO that gives the various drugs that have undergone one form of preclinical studies, because that's the first phase before you then graduate to clinical studies. And it's just to give us an idea of areas that all of us need to look at and expand our knowledge base and see whether any one of these options or more of these options could be explored in clinical trials so that we have other alternatives to management of mpox cases other than in addition to tecovirimat. Next slide. So let me just conclude to tell us here that in the absence of conclusive clinical efficacy trials, the management of mpox cases is mainly supportive and symptomatic. And it's important that we emphasize that comprehensive care of a mpox patient is multidisciplinary and involves several specialists, because the patient can present with varied types of clinical presentations and problems. So you need sexual health experts, infectious disease, dermatologists, surgeons, wound care experts, health, mental health, psychological support, nutritionists, social services for patients and relatives. And my charge here is that we will need to invest in further research to understand the efficacy of mpox for clade 1, clade 2 in Africa, of tecovirimat, I mean, in Africa. Then we also need to expand the landscape of antivirals that will be available to Africa, indeed the globe at large. Thank you very much. That's the end of my presentation.
Okay, Professor Ogena, really thank you very much, and Dr. Rashidatu as well. And this is a really great presentation. And colleague, you have seen really a lot. Oh, can you hear me?
Yes, we can.
Okay, thank you. Thank you very much. And you can see how the reaction is, people reacted to the presentation. And we had a really great information in this presentation. The importance of knowing the clinical sign, the disease epidemiology, in particular the incubation period, and how it can manifest in different individuals. And people have different way to express the clinical sign. You have seen it. And that, regardless of the skin color, whether you're white, you're black, it doesn't matter. And the virus can infect anyone, and it can turn to be even severe. The infection can be severe, can express in severe form of the disease, which lead even psychological disturbances. Sometimes people kill themselves, you commit suicide, you have seen it. And so it is very important to pay attention to that. Everyone can be infected with the virus, and the clinical sign can be different, but there is a treatment. There are potential, really, the medicine out there, drugs out there. Some are on trial, some are in advanced trial stage where decision can be made. Regardless of all this, it is important to address it timely. So, and that comes with the trust and knowledge of clinician as well. So clinicians play important role in this disease in terms of diagnosis, asking the history of the patient, and have a friendly, non-threatening, atmosphere, environment to create that one. So patient who suspected, they can come forward to avoid having this really severe form of the disease. And so regardless of that as well, even if you have the disease, your relatives and medical staff, really, they need to take care of all the patients equally as well, without discrimination. And some are malnourished, some patients, you need to consider that one. But you don't want to have to keep patients, then not giving them enough to really food or the other protective really means, so they can, if they are depressed, of course, that will portray bad image to the medical staff, clinician, and even non-clinician. And so it is very important to follow that. And there were some questions, and panelists, please look at the Q&A. There are questions out there. And so the Portuguese, some are in Portuguese, only a few. How incident is, the disease incidence is in Africa, and what effective treatment of the disease. We are not going back to the disease incidence because we covered that one during surveillance and epidemiology last session. We can share those slides with you. By effective treatment, you have all the answer to the question you ask. And now, if you want to get the scientific data for those, Professor Ogoina and Dr. Rashidatu, they can share some of these publications with you. And you can always go to any database and get those information. Now, so you can take a look at those questions, then we will come back to that during question and answer session, so it can be really very interactive, colleague can address it. So we will move to the next presentation because there will be a time for question and answer. Okay, over to you, please. Dr. Brian.
Thank you very much. Can you see my screen?
Yes, we can see it. Thank you very much.
Go on slide mode, please.
Yes, please. Can you confirm it's now on slide mode?
Yes, it is.
Okay. Thank you very much, and good day, fellow colleagues. I'm Brian, a public health officer with WHO deployed to support the mpox response here in DRC, and I'm currently based in Kinshasa. Thank you very much for the previous speakers who spoke at depth on prevention and control strategies for mpox. Here we are going to look at what are the different prevention strategies. We would look at vaccination, but also look in depth on infection prevention and control. Now, starting with vaccination and contact tracing, WHO has developed a framework through which we want to, work in stopping the mpox outbreaks in the African region. And when we look at vaccine, this fits into 3 out of the 6 core components of the WHO framework on mpox response. The first is protect.
Are you frozen?
Yeah, we cannot hear Dr. Brian.
Brian, please.
It seems that Dr. Brian has some internet issue.
So Dr. Deborah Barasa,
Yes.
yeah, maybe you can you can take over while Brian will connect.
That should be able to be.
He will try to reconnect. Or do you want us to give him a few seconds? Maybe Rosamond is on board. She can contact Brian to know exactly what happened. Okay, yes, over to you, Dr. Deborah Barasa, please.
Thank you so much. Dr. Brian was supposed to cover vaccination and contact tracing, and I was to cover infection prevention and control on behalf of the IPC team from country office, AFRO, as well as headquarters. So this is a collaborative effort. And so maybe because of the challenges he's facing, I'll go ahead and talk about IPC.
Yeah, thank you very much.
So the objectives is to look at the basic IPC measures to observe during a monkeypox outbreak within the facility as well as at home. And so we look at the aims and the benefits of IPC. IPC is really critical, number one, to protect yourself as a health worker, even for monkeypox and any other infections within the facility. Equally, it's important so that you can protect your patients so that we don't have infections moving from one patient to the other, and also protecting your family and the community at large. So IPC is everyone's business. IPC is important for us as health workers as we look towards protecting ourselves. So I remember Rashidatu had gone through this slide looking at transmission, and it has been shared severally by various presenters in this platform. This is the transmission, and as we remember, the transmission is anthropogenic as well as a zoonotic transmission. And the zoonotic aspect will be covered later on by Dr. Jessie. So we'll focus on the anthropogenic, which is the human to human transmission. So in this, we have transmission occurring via direct or indirect contact. And this can occur through infectious skin or mucocutaneous lesions, as had been described by Rashidatu. So face-to-face, skin-to-skin lesion, mouth-to-skin, mouth-to-mouth transmission can occur. Equally, there's respiratory droplet transmission and also vertical transmission, mother to child. Prof. Dimi had talked about this. And also indirect transmission, that is through fomites or the surrounding. Also, we remember a case where the shaking of linen also disperses the virus, and this can be inhaled and cause inhalation causing infection. So that also needs to be highlighted. Again, bodily fluids contact with the lesions and bodily fluids, contaminated surfaces, as we said, beddings and blankets are also at risk, and definitely sexual transmission has been highlighted by colleagues on this ground. So once the virus enters through the broken skin, the mucous membrane, or the respiratory tract, then it enters into the system. Rashidatu had talked about this, and then now infection sets in. So as it has been said by Prof. and Rashidatu, the patients are infectious until the skin lesions have crusted and the scabs has fallen off, and then there's re-epithelialization taking place. So for chain of transmission, for an infection to occur, we need to have all links connected. In this case, we are talking about monkeypox as the infectious agent, and then the reservoir. So in this case, it could be zoonotic or human, and then it exits the infected host, and then through the mode of transmission, it enters into the new host. And the modes of transmission, as we have said, may be through skin, mucocutaneous, the direct and indirect transmission that we've talked about. And then upon entry, if it meets a susceptible host, like a person who's unvaccinated, then infection sets in, and then the cycle continues, and there's amplification of infection. So for us as IPC, we are looking to break all the chains or all the links of transmission. So IPC is an appropriate measure to break this, and we implement a hierarchy of controls. which reduce the risk of exposure or transmission. So at national level and facility level, we need to have WHO IPC minimum requirements, which are aligned to WHO recommendations. So at facility level, again, we need to have standard precautions. And these are the basic level of IPC that are given to all patients at all times. So whether you're dealing with monkeypox, Ebola, cholera, during delivery, during a surgical procedure, the normal medical procedures, the chest clinic or the TB clinic, whatever it is, the standard precautions are really the bare minimum in a facility. And again, risk assessment is critical for all activities. So here we are just talking about the transmission and standard-based precautions. And as we said, standard precautions are really the heartbeat, the central part of IPC. For whatever facility, wherever you are, you need to implement. So once they are there, then the additional precautions or transmission-based precautions are those that are given for the disease at hand, but you have to have the core or the bare minimum, which is the standard precaution. And for this, as you can see, the first one is risk assessment. So why is risk assessment first? It's critical because cases are unique in each healthcare facility. Even if it's a monkeypox case, you may be dealing with vomiting or spillage of blood, you see? So what are the precautions for, how do you protect yourself, or how do you conduct risk assessment and mitigate against that risk when you are caring for that case? So risk assessment is number one and it's priority. Again, hand hygiene comes in second. And hand hygiene, when infections can move from one patient, you can transmit infection from one patient to another through your hands, yeah? So we really encourage hand hygiene, and we've just celebrated on the 5th of May, a hand hygiene day, and our webinar where we talked about how to protect ourselves through hand hygiene. So even for the monkeypox outbreak, we then emphasize on this. Respiratory hygiene and cough etiquette, yes, monkeypox is one of the transmission, as we said, is respiratory droplet transmission. So it's important that we emphasize that. Patient placement also, PPE use, we'll go into details on that. Aseptic technique, safe injections and sharp injuries. So there are many medications that they received. Prof. Dimi had talked about it. We are called upon to give injections in the facility. So we need to see how do we protect ourselves. And we were even highlighted that some of these patients are people living with HIV, hepatitis B, among others. So we don't want to get infected with that, as well as monkeypox. So we need to protect ourselves, and that is why injection safety needs to be highlighted. Again, cleaning and disinfection, linen management, waste management, and decontamination and processing of equipments. So as we said, this is the bare minimum, the standard precaution. And in addition to that, then we come to the transmission-based precaution. And for the transmission-based precaution is for the disease at hand. And this case is monkeypox. And for monkeypox, we look at contact and droplet transmission. Or contact and droplet, precaution. Then aerosol precaution if you're dealing with varicella zoster co-infection, or you're suspecting varicella zoster, that is chickenpox, then you need to have that. So these ones include isolating the case, having signages on IPC precautions that are needed, the PPEs that are needed when one comes into the isolation room, the equipments that are needed need to be there, and really limiting transport and also communicating to others about this transmission-based precaution. So for all this to be implemented, you will all agree with me that we need a multimodal approach. We are always asked, why are health workers not washing their hands? Why are there good IPC practices within the facility? So we need to build this. So I'll give an example of hand hygiene. We need to have the right infrastructure within the facility. Hand hygiene, infrastructure, yes, we need to teach. We need to educate them on how to wash their hands. We need to train them on monkeypox and how they should protect themselves, and then check it. We need to monitor the IPC practices during the outbreak and sell it. We need to have posters all over on hand hygiene, respiratory etiquette, Injection safety, we at times forget that, and the PPEs that they need to use, among others. And we have to have IPC champions within our facility. So I believe I'm talking to IPC champions and IPC focal points. Let us remember, standard precautions are the bare minimum. They need to be there. Then transmission-based precautions are now additional to the standard precaution based on the disease at hand. And then we need a multimodal approach in order to ensure that our health workers are changing their practices. So for screening, the case management colleagues went into details about this. And in screening, we are conducting an interview and an observation for the patient. We're checking for the symptoms and the contact as well as the local epidemiology. So symptoms and sign. While in triage, Prof. Dimi talked about this, we are categorizing them as mild, moderate, severe, fatal. Okay, so that's the difference. Screening is we want to see, is this monkeypox, yeah? And then triaging want to categorize, and then so that they can receive prompt clinical management based on the category or the prioritization. So for screening, what do we look for? We look for rash and fever or lymphadenopathy. Yeah, so this one, they went into extensive details. Rashidato talked about pustules, papules, vesicles, ulcers, pseudopustules, among others. So the rashes or the skin lesions may appear in different forms, and then they could be localized or generalized. Yeah, so anyone who comes with any kind of rash, a fever or lymphadenopathy, and it is aligned to the locally adapted WHO case definition, then they all have to enter the monkeypox clinical pathway. And as they enter, give them a medical masks, let them sanitize their hands and observe hand hygiene. And then you would want to isolate them in a well-ventilated room. And if this is not available, then you need to group patients with similar clinical diagnosis and based on the epidemiological risk factors, observing a 1 meter distance. So you can see the rash. I think this one has been covered very well with the case management team. So in the screening and triage area, what do we need? The area must be placed outside the facility so that anyone entering the facility is screened. We don't want the patients mingling with others and then amplifying infection in that case. So we need to have a sufficient place in this area where they're being screened. We need to have water, sanitation facilities, staff, a staff flow and a patient flow, and a physical barrier for the patient, where the patients are sitting on this side and health workers, and such as a table. But if this is not possible, we are not saying we need so much a physical barrier. You can always use just markers or something to ensure that we are observing the 1 meter distance and there's no touch process. But I believe you'll all agree with me, as health workers, at times we're called upon to care for the patient and have close contact. And in this case, we need to apply our standard and transmission based precautions according to risk assessment based on the risk at hand. Is the patient vomiting? Is the patient bleeding? Do you need to fix a line, etc.? So those ones are based on the risk, then you will have your precautions at hand. So even for the patients, the staff, we need to explain the importance of a uniflow, the flow of patients and the purpose of this. And we need to continue screening cases within the facility so that we are isolating the suspected cases from the non-suspected. Another thing we tend to forget is the inpatient surveillance. It's important that if you have an outbreak, you conduct inpatient surveillance so that we are not missing any cases within the facility. So the screening and triage area needs to be equipped. Some of the things they need to have: hand hygiene station, an infrared thermometer, a screening and a triage register. First of all, a screening tool, a triage register, and an algorithm so that they know what should I do with the mild, moderate, and severe cases. So case management will take that up. Waste bins, appropriate PPEs, and an area for donning and doffing. So this is an example. So meaning for all the patients who come in here, this is the entrance, they are screened, yeah? And for patients who do not meet, who do not have a rash, fever, or lymphadenopathy, or don't meet the locally defined case definition based on the WHO recommendations, all those who are non-suspects, now they go through the green area, and then they can be seen in any area that they need to be seen, like in the facility, like the pediatric cases and so on and so forth. But the cases which meet the case definition, yeah, these are the suspected cases. So they have undergone screening and triage. Then they enter the isolation zone. And in this isolation zone, we need to remember that first, we are separating the suspected and the non-suspected, but within the isolation zone, again, we are separating the suspected and the confirmed. And also, we are observing a physical distance of 1 meter, and we'll go into details of how we need to create an isolation zone within our facility. You can see an exit in case the patient needs to be referred, and you can notice that the exit is not the same as for the clean zone or the non-suspected, because we don't want them to mix. Again, you see that they have their own dedicated toilet, and we have a waste and combustion area, which we'll talk about further. Equally in blue, you see when the health workers have donned, then they can enter the isolation area, and there is an area for doffing. So for the isolation unit, as we said, is an area that we are separating the suspected and the non-suspected. And once
Dr.
a patient...
Deborah,
yes.
Sorry to interrupt, but interpreters have some difficulties to follow your pace. Could you please a little bit slow down?
Apologies.
So they can interpret more accurately.
Okay.
Oh, thank you, Mohammed. Thank you. Dr. Deborah, can you put your video on, please, while you are presenting? I think our audience would like to see you as well. Yes, great. Thank you. Over to you. Yeah.
Thank you. So in the isolation area, this is a dedicated place that separates the suspected from the non-suspected within the facility. And once a patient is identified as a suspect case, then they should definitely be separated from non-suspect cases so that we are not mixing up the cases. And in this isolation area, it needs to have clear signages and posters, as we had said, on the right PPEs to use, on the right precaution measures, in this case, contact and droplet precaution, and airborne precaution in case of chickenpox. Again, we emphasize that we are not cohorting the suspected with the confirmed cases. As Rashidatu and Prof had clearly said, there are many cases of fever and rash. They talked about chickenpox, molluscum contagiosum, syphilis, scabies, among others. So unless we have confirmed, we don't want to mix up patients because some of them may not turn out to be monkeypox. And if we mix, then we will get them getting infected. So we need to have a physical structure to isolate, but in case there's none, then we observe a 1 meter distance. We observe 1 meter distance and separate the cases. And as we said, we need to have an exit, but this should not be the same where patients are mixing with the non-suspected cases. Equally, there's importance of having ventilation, natural ventilation with no use of fans, and furniture, which are plastic chairs, you know, these ones are easy to clean and disinfect. And then, as we said, dedicated latrines or toilets for the suspected cases. So for suspected monkeypox cases, all health workers and even the patients, for health workers, we're saying observe your 5 moments of hand hygiene and implement contact and droplet precaution. And you use a respirator whenever there's a suspected monkeypox if there's varicella co-infection. If you're also suspecting a varicella zoster, wear a respirator because of the airborne transmission. And place the patient in a well-ventilated, single dedicated room. Or, which is critical, an airborne infection isolation for the varicella zoster. But if this is not available, then a well-ventilated single room with a dedicated bathroom and toilet should suffice. So what are the PPEs we need for suspected monkeypox? Gloves, gowns, respirators, yeah, eye protection, okay? And especially if you're dealing with the chickenpox, then respirators again are really important. And we instruct also the patient to wear a mask and also follow respiratory hygiene or cough etiquettes during transportation. Again, we limit transportation, but if there's need for transportation, we observe transmission-based precaution and we also communicate to the facility that is receiving the patient to ensure that the transmission-based precaution for monkeypox are observed. For confirmed cases, again, contact and droplet precaution, and in addition, respirators should be used, 5 moments of hand hygiene, and then we need an isolation room or area with proper signages. That is on contact and droplet or airborne precautions and the right PPE. So you can see this is one of the signages which can be used. And then they should wear the right PPEs for the case. So gloves, gown, respirators, and eye protection. And in case of movement, then they need to cover the exposed lesions and avoid unnecessary movements. Additionally, as has been said by the case management, the precautions remain until the lesions are crusted, scabs have fallen off, and a fresh layer of skin or re-epithelialization starts occurring. But again, I think there will be more guidance in terms of severely immunosuppressed cases because there's likelihood of viral shedding from the upper respiratory tract. And so upon consultation with your physician, then you will see when to stop the transmission-based precaution. For aerosol generating procedures, in these cases, again, we observe the same precautions. We need an AII room, and then we need to wear the right PPEs, which is a respirator, eye protection gown, and gloves. And then we need to perform aerosol generating procedures in a well-ventilated single patient room or an AII. So for cleaning and disinfection, this is one area that we are missing out a lot. This needs to be conducted as per the national or facility guidelines. We need to wear appropriate PPEs, which are the gloves, gown, respirators, and eye protection, and have dedicated footwear, but we are not wearing shoe covers, or we are not recommending shoe covers as WHO. And as we said, we first clean before we disinfect. Because what cleaning does, it reduces the load of contaminated surfaces so that you have appropriate contact with the disinfectant and it works effectively in terms of reducing infection. So remember, clean first and disinfect, whether it's the floor, the utensils, the reusable PPEs, etc. Let us remember that cycle. So again, just a poster which you can have in your facility to remind colleagues, and also on the right PPEs that are being used. Linen management, as we said, when we shake the linen, we are likely to inhale, we are likely to disperse the viruses and inhale this, and then it can cause infection. So we limit this and we carefully lift and roll the linen and we place in a designated container. So they can be machine washed if that is possible with hot water of more than 60 degrees and dried, or we can have also the linen soaked in chlorine, rinsed with water and allowed to dry. So while the people conducting this linen management or the hygienists, they need to observe standard and transmission-based precaution and wear appropriate PPEs. Again, for waste management, all bodily fluids and solid waste for patients with monkeypox are treated as infectious. First, we minimize waste within the health facility, and then we segregate the general, infectious, and sharps, yeah? And after that, we ensure that we are collecting well and we are transporting well. So the handlers, the waste handlers need to wear the appropriate PPEs. We need to have maybe vehicles, if we can't, wheelie bins or something that they can transport into the storage or treating area. I think that is one area that we forget, especially the PPEs for the waste handlers, so that they cannot be infected. Again, we store and ensure that it's in a restricted area where scavengers are unable to come in and collect, or children are playing. We don't want that, so we need to restrict the area and if possible treat locally, or ensure that the transportation is done well and dispose appropriately. Again, another thing we need to be passionate about as health workers is the 7 steps to safe injections. As we have said, monkeypox can affect even people who are co-infected with hepatitis B, HIV, among others, and also there are concerns of needle stick injury, yeah? So we need to ensure we have safe injection practices within the facility. So cleaning, we need to work on a clean workplace. We need to observe hand hygiene, safety engineered syringes so that we are not having reuse of syringes, and sterile vial of medication and diluent, and cleaning the skin and also ensuring appropriate collection as well as waste management for the sharps. So again, this is an area that needs to be highlighted within the facility. How about visitors and caregivers? We need to educate them also and perform appropriate hand hygiene before and after entering, the right PPEs to use. And also for the vulnerable individuals, we need to discuss with them and see, are they high risk? Are they informed before they make the decision to come and visit the patient, okay? And consider other alternative forms of communication, such as video conferences. For home-based care, a home assessment should be done. So it's not just about categorizing the priority that the mild cases are going home. What are the IPC measures, yeah? Are they accessible and available IPC wash measures for home-based care?
Dr. Deborah?
Yes.
Sorry to interrupt you. You're still going very fast. The interpreters, they cannot follow you. So the Francophone and the Lusophone are not following your presentation. Please slow down.
Okay, sorry for that. So the patient and designated persons that they need to be taught on self-care, and also the caregiver need to be in good health. They need to be vaccinated against smallpox and monkeypox. And we should identify people who are not from high-risk groups, because they are likely to even have severe infection. So we isolate them in a separate area from other household members and away from shared areas. And clinically, these patients can also be followed up through telemedicine or telephone. For health workers who are visiting cases at home, they need to wear appropriate PPEs, perform hand hygiene, and also taught about cleaning and disinfection of patient care equipments. And in the case, if the case has to visit a facility, then we need to inform the facility at hand. They need to come wearing masks and covering their skin, the skin lesions. Again, we need to observe cleaning and disinfection, linen management, and waste management protocols as described earlier. So for occupational infection, yes, some health workers have gotten infected with monkeypox as they performed activities within the facility. And so we need to look or highlight on occupational infections. So the staff need to be screened and tested if they meet the case definition, and staff illness protocols, return to work formulas need to be available. And to ensure that staff also stay at home if they're unwell, we need to have those policies without loss of income. We need to have blame-free reporting and investigation of unprotected exposure among health workers. And we need to address issues of staff to patient ratio, shifts, rest periods, administrative or environmental risks. So we need to ensure that our health workers are safe, they are in good health, previously vaccinated against smallpox and monkeypox. And also we need to encourage them to report both occupational and non-occupational exposures. So for managing health worker infections, we need to immediately isolate and stop all patient care activities. Then they need to inform their supervisor and seek care if they're feeling unwell, and health workers should seek return to work formula or advice. So that is it from me. Thank you.
Thank you very much, Dr. Deborah Barrasso. And that's a great presentation. My colleague, please use the chat, use the question and answer to give your question. And really, this is a great presentation. Again, we will come to the question and answer soon. And Dr. Brian Young, you have the floor. And thank you for sharing your presentation as well. In case the connection dropped and we will project it. Otherwise, over to you. Thank you.
Thank you very much. And as well, apologies for the connection issues. I'm also connected on 2 devices to ensure that we no longer have that interruption. So I was just, trying to explain this framework and how the immunization strategies, which we are going to talk about, would fit into the WHO framework of mpox outbreak response in the African region. Immunization really falls into 3 main components of this framework developed by WHO. First is ensuring that we can raise awareness and empower communities to adopt protective measures, including vaccination, improving access to diagnostics, vaccines, and therapeutics for mpox, and as well driving cross-cutting research agendas, including research on vaccines and how best vaccines can be used to stop the chain of transmission. Now, among the vaccines, that have really been studied and looked into to be used in an mpox response, the SAGE actually came up with 3 main vaccine candidates. We have the modified Vaccinia Ankara vaccine made by Bavaria Nordic. This is a non-replicating vaccine, which is based on the Ankara or the Vaccinia virus, and it's a 3rd generation vaccine, usually administered in 2 doses, 4 weeks apart, and it's a freeze-dried vaccine, which is administered subcutaneously or intradermally. The next is the LC16 vaccine. This is usually administered using a bifurcated needle. It's made by the Japanese company KM Biologics. It's a minimally replicating vaccinia-based vaccine as well from the 3rd generation. The last is the ACAM 2000 vaccine, which is actually a replicating vaccine and of 2nd generation and also administered through a bifurcated needle. Both LC16 and ACAM 2000 are administered as single-dose regimens. Most of us connected here maybe have not, seen the bifurcated needle being used ever since it was used in the smallpox vaccination. WHO has actually developed guidance on how to use the bifurcated needle. You have a link here, and when we share that slide set, you'll be able to have access and you can look at what are the different use cases, how the bifurcated needle is actually used to administer the LC16 and the ACAM 2000 vaccines against mpox. Now, in terms of operational strategy, the SAGE really looks at 2 different modes of deployment of use of the vaccine in a response setting. The first is primary prevention, where we administer the vaccine prior to exposure of the patient. And in this strategy, it should be groups that are at highest risk of transmission should be prioritized. In the ongoing, in the pandemic that was declared that affected mostly the Western world, you really had a focus on, gay and bisexual men and men who had sex with men. But as well, in other settings, like in Africa, you have sex workers in areas where you have ongoing sexual transmission, like the eastern part of DRC. You also have healthcare workers, laboratory personnel, and also those in the outbreak response team that frequently come in contact with the virus. As well, you also have post-exposure preventive vaccination. And here we give the vaccine will be administered to those after they have been exposed to the virus. And usually it's ideal to administer the vaccine 4 days after exposure, but it's recommended up to 14 days. if the patient haven't developed symptoms yet. Now, looking at the latest data from SAGE on the vaccine efficacy, it's worth noting that this efficacy data is based on the MVA-BN vaccine. For one dose of the MVA vaccine, the efficacy is 76%. You can see the confidence intervals, which are quite narrow. But as well, for 2 doses of the vaccines given in the pre-exposure phase, we can see it's about 82% vaccine efficacy. So I think the take-home message here is to have optimal protection, is best to use the vaccines as a pre-exposure primary preventive strategy. Nonetheless, in post-exposure, you have a vaccine efficacy of about 20%. And sometimes some of the reasons why we are seeing a low vaccine efficacy in the post-exposure strategy is, trying to get these contacts vaccinated within the first 4 days, which is not very easy to do. But as well, it's worth noting that these studies were done during the pandemic, and maybe sexual transmission is very effective, more effective way of transmission, and that also shortens the incubation period of the disease. So that could be some of the reasons why we are seeing a very low post-exposure prophylaxis efficacy. Now, looking at the new SAGE recommendations, which were deliberated upon in March this year and are yet to be published, here are some of the new guidances that were provided by SAGE. I think the first, which is worth emphasizing on, is whatever vaccination strategy is developed should really be based on the local epidemiology of the disease. So each country that wants to vaccinate needs to look at these recommendations and take them into consideration, but also look at how that applies given the local epidemiology that we are seeing that are seen in the country or in the affected area. For example, here in DRC, we have certain parts where we know that about 90% of transmission is sexual transmission, for example, in the Eastern DRC. Now, in those areas, it would be worth, focusing on the groups that are at highest risk, such as sex workers and such as those who have multiple sexual partners. So that's really, ensuring that whatever vaccination strategy we use is really based on the local epidemiology. As well, healthcare workers with repeated exposure should be vaccinated, and contacts as well should be administered the vaccine. So contacts of a confirmed case of the disease. And the SAGE actually notes that the identification of population at risks of exposure could be limited in certain settings. And also in some settings, epidemiological data could be limited to really understand the transmission dynamics. So now looking at the next set of recommendations, looking outside an outbreak setting, who are those who should be prioritized for the mpox vaccines? This is mostly those who are handling the mpox virus or other orthopox viruses. It's recommended that they should be vaccinated, but as well, given that the duration of the protection as of this moment is not yet well understood, WHO recommends vaccinating these persons every 2 to 5 years, according to what is practiced in 2 of WHO collaborating centers. Now, for immunocompetent individuals, WHO actually recommends the 3 different vaccines that we've spoken about. So the non-replicating MVRBN vaccine, the minimally replicating LC16 vaccine, and the ACAM 2000 vaccine. For children, the LC16 virus is the one that has extensive safety data compared to the other mpox vaccines, and this is actually the vaccine that is recommended for use in children. Nonetheless, in exceptional cases, the MVA vaccine can be used, but this would constitute an off-label use, and WHO actually recommends that in this case, it should be the vaccine should be deployed, and we should have good studies in place that can document any safety concerns or any safety issues that may come up. Minimal replicating vaccines such as ACAM 2000 are not recommended to be used in infants. Now, in terms of contact tracing, firstly, I know you guys already had a session with Dr. Thomas Nakpe on mpox surveillance, but we are just going to look at one slide on contact tracing. So the entire contact tracing process starts with a confirmed case, and this confirmed case would have been in contact with others. And by contact here, we mean, having physical contact. Having contact, skin-to-skin contact. It could be sexual contact as well. It could be, handling contaminated materials or coming in contact maybe with an animal that has been that have been confirmed to have the disease, or having a long face-to-face contact. So not having physical contact, but prolonged face-to-face contact as well with a confirmed case. Like we saw previously, you can actually have infection through droplets. So when we have a confirmed case, we are actually supposed to do contact listing. So list all the possible contacts which the person would have had while they were infectious, and follow up those contacts for 21 days. During that period of following up contacts, it's recommended that a health team should actually be in contact, should actually follow up the development of symptoms, and actually physically meet these contacts throughout the period of contact follow-up, and to have a chat to know if they are developing symptoms or not. Should they remain symptom-free, then after 21 days, they can come off the contact tracing list. But should they develop symptoms within 21 days, then they would be classified as a probable case of mpox, and additional testing should be done to confirm whether those symptoms are actually due to mpox or not. Thank you very much, colleagues, and happy to take any questions. Over to you, the chair.
Thank you very much. And thank you very much for the presentation. All panelists, now welcome to the last part, which is a question and answer session. And I think we have our technical lead, Dr. Rosamond Lewis, with us here. Probably we can invite her if she got any observation, suggestion to add to this. Dr. Rosamond Lewis, you can put your camera on. I know if you are in the DRC or Geneva, please take the floor and give few words before cracking on with the question and answer. Thank you.
Sure. Well, thank you very much. Merci, Thierry. C'est un plaisir d'assister à ces présentations vraiment superbes qui couvrent beaucoup de matières. These are very rich presentations covering a lot of ground. I don't have any specific comments other than to say, yes, we continue to support you in your work on mpox prevention, control, outbreak response, working towards access to vaccines in the region. And anything that we can do to support, please don't hesitate to ask or raise your issues here. I'm happy to support the other team members in addressing questions. Thanks.
Okay, thank you very much, Dr. Rosamond Louis. You've been very active in this, always with us on the ground, in the office, every time messages, and you know, when there is one case, receive a message. What are you doing about? Okay, that's right. Yeah, we need it. You are full of energy and enthusiasm and really dedicate your life for the health, and which is very important. Thank you very much for all your support. And we believe some of this material, you can take a look at it. If you think we can put it in open WHO, please just with the presenter, we can craft it in a way it will fit for purpose. Thank you very much.
So that's a very good suggestion. We also have what's called the Outbreak Toolkit on the WHO website. So it would be possible also to put sample slide sets that people can use for training in your own contexts. We could create a little toolkit within the toolkit for things like that if you'd like to use that space as well. Otherwise,
Okay.
yes, Open WHO trainings online, those are available on mpox, as well as all the other things you've mentioned, infection prevention, control, and so on.
Okay, thank you very much. Then the other thing is we have Professor Dimi Ogena, Dr. Brian, Dr. Deborah Barasa, and Dr. Rashidatu, colleague at country level or regional level. In case you really want to reach them, you know how to do it. You can contact them. And if you have an outbreak, you are dealing with cases, and if there are some clarification you need, please reach them. Now we can move to the question. Really, panelists, thank you very much, and for the great presentation. This is the beauty of collaboration. Now, there was one question, but some of these questions are very easy. We can always provide answer. One is, since mpox is a zoonotic disease, can you elaborate on the integration of surveillance of animal in the response prevention of mpox? I think you have seen a slide where you saw exposure to animal, infected animal is really an important issue, and it is addressed as well during the investigation. So the question was addressed last week, and here as well, it was on several presentations. I think when you have the slide, you will see that importance. And it was addressed to Dr. Brian because the colleague mentioned that the tests are being used in endemic region, especially in the DRC. And DRC can address some of these. FAO was doing a project in some of the provinces where they collected samples from animals and tested. And myself, I have done that, not for mpox, but it was for Ebola. And so we use, really, we consider animal as well because it is a zoonotic disease. Now, for mpox, yes, we addressed that one. And Rosamond, Dr. Brian, they were in the field. They did really large mission. And that mission led even to another policy briefing mission. So that's very important. They look at all these One Health aspect you talk about. And we have a platform as well, One Health platform, DRC. They're very active in mpox. So, and now the other one question is someone addressed Rosamond, I think you are on board. We should also move to the change the name of the virus for monkeypox virus to mpox virus. I think this was addressed again, and it is about the change of the name. So, colleague, you will address that one. And the rest, I think we can give the floor and for panelists to look at those questions. We start with Brian, then we come back to Professor Dimi and Rashida too, and how we can close the question, the last word about this. But colleague, for those who keep asking for the presentation, I think we mentioned that you will receive the presentation and the recording as well, which is great. So if we keep asking the same thing, it just shows that we don't follow instruction. And then not following instruction is a big problem. It is a challenge because it means probably whatever you learn here and applying it will be a problem. Wherever you learn, it doesn't matter where you learn from. And but we will try our best next time when you register. So there will be centers below. All presentation will be shared, and a record will be shared as well. So so you don't waste your energy in pasting these things all the time. Thank you very much. Okay, over to you. And Dr. Brian, if you look at the question, please. Yeah. You want me to project it? I can project from my
yes,
side.
please. Yes, please. When I got disconnected, when I reconnected, I didn't have access to the questions.
Okay, I will project the question
that were there before.
And you can see where these questions are. Okay. Usually, okay. Can you see my screen? Can you see my screen?
Yes, please,
now?
I can. Yes.
Okay, I reduce the question a little bit. Oh.
Okay.
Right.
Yes,
Too
I
big?
can. Yes.
Okay. Mohammed, can you see? Amarachi? Yeah. Okay.
Yes, we can see. We can see.
Okay,
it's
fantastic.
Okay.
Yeah. Okay. Over to you. The first question.
Okay. So I think the first question is the experience from TRC on integrating surveillance, both human and animal-based surveillance. I think that's a very good question, and I think it emphasizes, the point that firstly, mpox is a zoonotic infection. So no matter what we do, in trying to break the human-to-human chain of transmission, there is still that aspect of spillover events from animals. So recently, we elaborated a response plan here in TRC, and we emphasized on this One Health approach to ensure that we can try as much as possible to integrate response activities, both integrating the human and the animal parts of the response. So what is ongoing now, particularly in the Equateur province, and we are also pushing to have that decentralized to all the different provinces where the response is being set up, is to ensure that we actually have both of humans and of animals, and to ensure that our colleagues working with both domestic animals and wild animals actually have also their community health workers who actually do surveillance of these animals and ensure that they also send out alerts. They also collect specimens which are sent to the laboratory. Among the specimens from animals that have been collected thus far as part of the response, none of them have tested positive yet. But, you know, that's still a work ongoing to ensure that we can understand what the animal reservoir of this disease is. There are a lot of challenges as well, you know, in practically implementing this One Health approach. But nonetheless, we think that here in TRC, we are making progress, albeit slow, to ensure that our response is really One Health centered, given that the disease is primarily a zoonotic disease. Thanks.
Okay, thank you very much. Thank you very much, Brian. And collaboration and coordination, communication, very important between sectors to address any zoonotic disease, in particular mpox, which you have seen during the presentation, and started with risk assessment, preparation, preparedness, and so these are all important. I think DRC is setting already good example in terms of even decentralizing One Health, national One Health platform into at the lower level. I think you cover it very well, and the challenge will be always there, but with good communication and awareness, and in terms of whether it is whatever was presented here, and infectious prevention control, you have seen the different the approaches outlined, but how do you approach it is very important, because there is a sensitivity. Even how do you manage cases, sensitivity, because if we really do it, we approach it very well, and taking into consideration social dilemma, I think it will give opportunity to patients, even at the community level, because people at the community level, if they master all these basic, what is needed, and become health conscious, know about it, have the knowledge, accept it, and use that knowledge to change even the attitude toward any type of pathogen, we will make a big impact. So, and just to follow up, Professor Ogena, you have a question here where they ask, that's kind of thanks for the presentation. What has worked well for children? I think this is due to the question related to the management of cases, pruritus, probably advanced severe cases, where then you can just please a little bit elaborate on this. And Dr. Rashidatu, I think they talk about, they ask a question whether it is what is common. I think this, we can have this information. It was covered, and any type in Google, you find out. Colleague, sometimes when you give a question, practical question, if you've been dealing with disease, I think that will help. I'm not discouraging you to fire a question, you can. But some of these questions, the answer was given 1,000 times. You can find it on any network, but it's so good. Professor Ogena, please, for management.
Okay, thank you very much. If you look at the WHO recommendation, of course, from how therapeutics are used, based on prior studies, loratadine is not recommended for children less than 30 kg. So I think in answering this question, I said it's important where you have access to a pediatrician to also seek for advice, so that you need to look at the patient as a whole, because you could alternatively look at sedating antihistamines like promethazine. And sometimes what we do for children that are below 30 kb is to also look at, for instance, lotions that can reduce pruritus, like calamine lotions. So that is given, and we can also consider promethazine, but promethazine is sedating, so we need to be cautious about giving that.
Yeah. Okay. Fantastic. And okay, really thank you very much again for the brilliant answer. And those who gave the question, so they heard about the answer now, and there is a skill and There is that is needed, and knowledge of what you give and the context. And so that's very good. And Dr. Rashadu, and yeah, you have any final remark here, please?
Sorry, Dr. Rashida took an excuse to be away, so she's not around. So if
Okay,
there are
she's not
specific
around.
questions from her, I address it myself.
Yeah, right. Okay, that's fine. And we have the other panelists for final remarks before we thank the interpreter, Dr. Deborah Barasa. Any final remark about takeaway
So
message, please?
yes, Dr. Soro is here. I would wish you give him maybe a minute or two to also give some remarks.
Yeah.
Soro?
Okay. Yeah.
Okay,
Then-
thank you so much,
Yeah.
colleagues, for the nice presentations, and then including the IPC presentation. So as you know, the monkeypox virus, as research is still ongoing, you will see some of the thinking on IPC. We do not have yet some clarification, especially on the contamination and disinfection of patient linen. We talk about the chlorine solution, but you notice that we did not give you the exact concentration of the chlorine that we have to use for the medical equipment the patient linen decontamination. So as we are moving, we also getting information as research is going. So more information will come. And thank you so much to everyone. And I hope you appreciate all the presentation. And thank you so much to Traore for the nice animation of the workshop. Thank you.
Thank you very much, Dr. Lassina. Thank you very much. And we still have a few questions and a suggestion from Professor Ogena. And some colleagues have their hand up. Mohammed, probably, if you can list them, we take them in order. Otherwise, if the question been addressed in the Q&A or during the presentation, maybe we can save time. Otherwise, there is one question which say how to prevent mpox and even a reinfection. Is it possible to have a reinfection? That's one. That's an immunological question. And the other question is, if the vaccine is available in Africa, what age group should be used? And okay, let's do the vaccine first. Dr. Brian, you present about the stage, and I know Rosamond is on board as well. She's been working on it, to publish on it. And please, you can address this so we can move to with Mohammed. Thank you.
Thank you very much. Regarding the different age groups to vaccinate, according to the SAGE recommendations, it's really, taking into consideration the local epidemiology of the disease. For example, here in DRC, we actually see that the most affected group in terms of number of cases, but also in terms of death, are children below 15 years of age. And in certain areas in the country where you have sexual transmission, we are seeing a lot of transmission amongst sex workers. So we are currently also working to develop a vaccination strategy for the country, and we are really putting that epidemiological picture at the center of our strategy. That means in areas where we are having a high number of cases and deaths from children, we are planning to prioritize them with the vaccine that actually has a good safety profile to be administered to children, such as the LC16 vaccine. And for areas where you have more adults that are affected, more sex workers. We are actually working on a strategy to ensure that we can target commercial sex workers, but we can also capitalize on the experience from the HIV program to know how we target those with multiple sexual partners. So in terms of defining a vaccine target, we have vaccines that can be administered to different ages. LC16 has a good safety profile in children and also can be given to adults, but MVA is recommended for those above 18 years of age. So we have vaccines that can span all these age groups. Now, the way they are deployed to the field as part of an emergency response should really be defined by the local epidemiology of the disease. Thanks.
Okay, thank you very much, Brian. And for those who have immunization group as well, advisory group in the country, they can always contact them in case they are in doubt of any of the issue. And Rosamond, are you with us? Okay. Okay, over to you, please.
Sorry, the question, please do.
No, it was vaccine, Brian addressed it. In the case if you want to, the availability of vaccine.
Oh, right.
Do you have enough dose? That's it for us. I've been asking you since last year. Do you have enough dose for us?
Right. I think we need to backtrack a little bit, right? Before we can ask, do we have enough doses, which is a very valid question. Are countries interested? Do countries want the vaccine? Because there is work to be done on both sides of the dose divide, if I can call it that. In country, there must be a process for regulatory approval of the vaccine. So vaccines can be brought into any country for the purpose of clinical studies, for the purpose of emergency use, or for the purpose of regular market authorization. And then there are different ways to approach even those three things. So it can be a process that has to be decided on at country level as to what they would like, what national authorities would like to do. There are ways to go about getting support for all of those things. So if you're looking at LC16 vaccine, the government of Japan is interested in providing support by providing review of the files that they have collected for their own regulatory approval. For MVA-BN, it's the same. We have regulatory approval from the European Medicines Agency, from the US FDA, from Health Canada. Those countries are all willing to provide support to any country to review their file directly for the purposes of emergency use. And then if you actually want to proceed with a full authorization, the company Bavarian Nordic is also willing to apply for full registration in countries that would like to go down that path. So again, the whole regulatory process, we have Dr. Kwasi Nyarko on staff in the regional office at WHO, African Regional Office, who is very knowledgeable also about how to embark on clinical studies, if that's what you'd like to do, or support for regulatory review for emergency response. All of that actually precedes the questions, the very valid questions that you're asking right now. Well, actually, they go hand in hand. So what population groups would you like to vaccinate? It depends on your epidemiology. What vaccines would you like to use? It depends on your epidemiology and the regulatory process you proceed to follow. So it is a whole area of work that requires dedication and time to consider the different options. WHO has not pre-qualified these products. There is discussion ongoing about that, but even pre-qualification is a longer term path. It can take 2 years or upwards. So that is not an immediate solution for countries who would like to use the vaccine right now. So right now, immunization strategies are critically important to target those at highest risk or at high risk in any case in any given context. But even with that, once the strategies are in place, then we can say, well, is it possible to mobilize these quantities of vaccines, or at least some to prioritize further? Even with all of that, you will still need approval to import the vaccines in country. So back to the regulatory route.
Okay, thank you
Country
very
may
much.
find just to give an example, we do have colleagues from Nigeria on the call. Nigeria has recently approved the use of MVABN for emergency use. It is a process that took 1.5 years with the direct support of the US FDA. So we've taken that as one example where a country has actually now succeeded. But also taking it as an example of how to learn lessons from it to move it faster. If it's emergency response that is the desired option. So then 1.5 years is a bit long. So we can learn lessons from everything we are doing right now. Learning by doing is what we call it.
So I totally agree with you. Thank you very much, and into the enlightening. And as you point out, you know, there is always a need assessment. Do you need it? Do you value it? And the uptake will be easy with that one. And you cannot force anyone to do that. But I think this is a part of our work to work together, really to use all the available tools to stop the transmission. And there is a way to do it, and you will describe it as well. And that will even facilitate the work of Professor Dimi, Dr. Rashidatu, because they will not see any severe cases again, like what was shown on the picture. If you have a good vaccine, you prevent the transmission, and you can even reduce the severity of the disease because the immune response will be different. Yes. Okay. Anyway, we can, Mohamed, do you have a hand up?
Yes, we have 3 hands up. We can start with Mr. Hassan Sware.
Hassan. Well, okay. You can per order. You can name them, please. Okay, you can call them. Thank you.
Unmute yourself.
Right. Can I come in now?
Yes, we can hear you. Please go ahead.
Thank you very much, and I want to appreciate the presenter for this wonderful presentation today. It's not like a question, it's like a comment. I still want to hold the view from last week presentations with regards the monkeypox posters, signs and symptoms, and the confirmed cases we are getting for the mpoxes. So far, since the start of this webinar, all the presentations so far I've not seen a unique cases that are a bit different from the posters of the signs and symptoms for the mpox, because I still believe and I hold the view that every country and every cases reported must have a unique feature that is very different from the generic signs and symptoms posted on the website. Having participated in so many outbreaks, and then I have the view that we still have unique cases. So I want to see moving forward with the presentation, let's be seeing those unique cases, whether there has been any difference in the signs and symptoms which we are seeing as a unique posters on the internet, so as to help or guide other countries to see how best they can prepare themselves. Because if we are not seeing these posters or these unique cases in all the countries that are reporting confirmed cases, some real, some else, we are missing some cases. So that is why I still have the view that some countries are still underreporting or maybe over-reporting. So we must see those cases. So the next presenter coming, if there is a country is going to present, let's see the uniqueness of the case or the cases they have. That's what I want to see. And thank you very much. And I want to appreciate the organizers of the program. Thank you.
Okay, thank you very much, Dr. Hassan Sware. Yeah, I was here last time. You asked, and I did say there are a lot of posters out there. The country can take picture, and and just look at those cases. As Professor Ogena presented, you see there were clinical cases with clinical symptoms, cases without clinical symptom as symptomatic cases. Now move to clinical one. When you move to clinical one, you have variety of expression. The expression of clinical sign varies depending on the patient and depending on the context as well, in the context as well, on the context, because you live in an environment, you have interaction with pathogen, hosts will always react differently. And take the nutritional status, take all the parameters into account. So this clinical sign will be different, place to places. Now, I give you example of a good model for DRC. Rosamond is on board, she can witness, a colleague from DRC, they are on board. There is a platform, WhatsApp platform, for different partners interested, a stakeholder, I can name it, interested in mpox or other zoonotic diseases. So on that platform, you will have sometimes picture of cases, clinical cases, from one place to another place. So we don't show the faces for confidentiality and for ethic purpose as well. You can close that one, but sometimes it is shown. But that country can share that information among themselves and between partners as well. So they see advanced clinical cases or even mild clinical cases. So the system is there for them, but I leave this question to the panelists. And Professor Jimmy, you want to address this one? Because I know you have seen a lot of cases in Nigeria and on the presentation, and is among those first authors to find really to demonstrate sexual transmission or sexual cases linked to sexuality. Professor, again, please take the floor.
Thank you very much, Trevor. I think it's the question or the comment that has been raised is very valid and important because we may have a tendency that we're underestimating the number of mpox cases we have in Africa because we are not recognizing what I call the new type of mpox. We have been, over the years, familiar with the typical classical type of mpox, and we have now observed that there's a new type of mpox that is largely sexually transmitted and clustered around the anogenital area. So I think it's a good point he has raised. And I think if I'm correct, for Nigeria, for instance, the surveillance CRF that they have made provision, for instance, to provide pictures of typical lesions. So for instance, you know that mpox is supposed to present with macules, vesicles, of macules difficult to see, vesicles, papules, pustules of that, even ulcers. So what is done is to put various pictures of different categories of lesions. So that whoever is going out in the field or the surveillance officers, epidemiological officers have a general picture of how mpox is expected to be. So I think what's also important is that clinicians that work in peripheral centers outside the major tertiary hospitals are also sources of diagnosis, and they're not within the surveillance system. And you need to increase the index of suspicion. And so that's why what he's saying now is important. So if we have a way where posters are done in such a way that we have the variable presentation of mpox depicted in such posters, and we increase awareness, especially in the public, because I believe a number of people in Africa have mpox, this new mpox. They have dismissed it as perhaps a sexually transmitted disease or perhaps a different type of skin rash. On account of that, we are missing cases. So a poster is one of the ways to resolve that problem. Thank you. Over.
Okay, thank you very much. Yeah, thank you, Dr. Hassan Swari. I think you got the answer, and you know how to get now the information. We can all work together when we have a team at the HQ, Rosamond team, and they can help as well craft any poster and put them in a way that will communicate to the public and to ourselves as well. Okay, Mohamed, over to you. Thank you.
Okay, Mr. Florimon Choko Quenteminga, please take the floor. Mr. Florimond? Choco? Okay. Mr. Honora Akodegeno. Chidonu? Honora?
Yeah, I'm here. So do you hear me?
Yes, we can hear you. Please go ahead. Mr. Honora?
Mr. Honora?
Yeah, do you hear me? Do you hear me?
Yes, we can hear you. Please go ahead.
Okay, thank you. So I want to greet all this presentation is very good, and I'd like to thank you for WHO also for giving me this opportunity to participate this webinar. But this webinar is very good for me, and I want to ask some question to Professor Aigona. Because in your, do you hear me? In your first lab? Hello?
Please go
Yes,
ahead.
we can hear you. Go ahead.
Okay, in your first lab, that you are, the some part is there where you are put the marker, the question mark in the curves for the reinfestation. It is possible the people who have the monkeypox can be reinfected again. That it is my first question. And it's possible we have when the people have the monkeypox in fever, we have the drug we cannot give them if you have the fever in monkeypox. I want to know this question. That is my second question. And I went to do some commentaries when you give me opportunity. So I know that in Guinea, many of workers don't know about monkeypox. That it is why I went to initiate another subject to do some studying to know the knowledge of the health worker in Guinea from to monkeypox, because we have monkeypox in Liberia. We have the case confirmed in Liberia. Guinea is the Liberia, the country neighbor of Liberia. So many people, I discussed with some of my friends who have medical doctor, and he don't know about monkeypox. That is where I'm very afraid and about these situations, because when we have the monkeypox in Guinea, the people will be very dangerous for this epidemic in Guinea. That it is my comment. Thank you.
Okay, thank you very much, Honora. Okay, Professor Demi, over to you.
Okay, thank you very much for that question regarding reinfection. And so, of course, from epidemiological data we have now, even from Nigeria, we have mpox cases that have had reinfection. I think this idea of, well, the spectrum has to be very clear, because there could be new infection. As for instance, we had a case in my hospital that came in with active skin lesions. And when some of the lesions were recovering at the phase of desquamation, new lesions appeared. So that's not necessarily reinfection. We could also have relapse. For instance, in the UK, a study that was done before the 2022 outbreak, it was observed that one of the patients that was admitted and was discharged developed sort of a relapse of a skin lesion, an inguinal lesion, 6 weeks after discharge. And of course, this current outbreak that we're seeing, there are a number of cases of relapse that have been reported. But reinfection itself, for instance, in Nigeria, what we reported is that somebody developed a reinfection 10 months after the first infection. So reinfection has been reported, but we need to be very clear whether some of these infections, whether the patient are fully recovered, because some people are not fully recovered. And because of the severity of their illness, they may have apparent recovery and have a relapse as opposed to reinfection. Of course, one of the ways of to be very sure about reinfection is to look at the genomic sequence of the virus, whether it's the same virus or different viruses. So what that tells us, even from the 2022 outbreak, studies that have been done mainly in Europe, it has also shown that even people that have been vaccinated have also developed reinfection. So for that case, not for the population, for that case, vaccination did not prevent reinfection. A study that was done during the 2003 US outbreak looked at the immune response to mpox in terms of humoral and cellular immunity, and looked at natural immune response in terms of how much do we have the enduring immunity after natural infection that could prevent a reinfection. And I think in that study, people lost their immunity after a period of 1 year following a natural infection. We're not too certain about the duration of immunity following vaccination because we have not had shown that the immune level substantially even after 6 months. So just as a form of summary to say that reinfection has been reported even in Africa, and it is possible to have reinfection, but we need to be clear about new infection because the patient can be admitted in the hospital with resolving skin lesion and develop a new infection. And a patient can also do a reinfection after recovery, and the patient can also have a relapse. So there are several spectrum, and I believe that we need to work more to define some of these conditions very clearly. Yeah, over.
Okay, thank you very much, Professor Ogana. And Mohamed, another last one, probably, so we can close.
Yes,
because
we
it
have a
is
last
48 now. Yeah.
Obina Onua, please take the floor.
All right, thank you very much. Good afternoon, everyone. This is Obina from Nigeria. So yes, it's not news that we are expecting doses of the mpox vaccine, the MVA brand to be specific. So we are in the process of trying to develop risk communication materials. We should naturally go out before these vaccines should be deployed. And, in trying to build trust and to ensure that the intended audience, are willingly able to accept the vaccines, we are trying to see what kind of communication should be able to be placed or sent. So, if you look at the Q&A, I did ask, are these vaccines WHO certified? And currently, the answer is no. So I'm sort of like trying to find out what kind of communication could one pass to try to say, some authority has looked at these vaccines, and of course, being specific to the country Nigeria, what kind of communication can we use to try to bring some level of, should I say, confidence or acceptance that this is safe to use? Thank you, and over.
Okay, yes, thank you very much, Dr. Obina. Thank you very much for your question. And this we will take this as a last question, and then we will thank really panelists because for the time and participants as well for time. We had over 300 participants. Now it is dropping. That means it is time. And okay, Brian, Dr. Brian, this is for risk communication, and Rosamond is around, and I will just give you some hints. And if you look carefully, some of these vaccines were used in the global outbreak. And based on the data available on this, one can craft the risk communication material. And risk communication sometimes, you need to be well elaborated with community themselves. And rather than we just go and we say, okay, we do this. Sometimes it is very important to base on the past, on other diseases. It could be measles, it could be yellow fever. We had a good output, a good kind of really the example of use of vaccine. And some cause kind of concern when people interpreted it badly. But at the end of the day, we have a good example of polio, for example. And so some of the disease, take rabies. If we didn't use dog vaccination, rabies will be all over the place, even in Europe. And so these are examples where you can channel, craft it with the community themselves, say, okay, the vaccine use will reduce the transmission or the impact of the infection. It has been used in Europe, but how do you put that in the context? So a colleague can, community, ourselves, we can trust it. And I think that's the skill. And we have a team, risk communication team with expertise in this, and based on the questionnaire they develop to work with community. Brian, over to you, please.
Thank you very much, and thanks, Obina, for that question. I think it's a very pertinent one. I think the era of COVID-19 has made us to understand that at a certain point in time, it's not only useful to have public health tools such as vaccines, but ensuring that we have optimal uptake of those public health measures could be quite tricky, and that's where having a good risk communication strategy comes into place. I think for whether these vaccines are currently licensed by WHO, I think the answer is no. I think Rosamond can speak a lot more to that, but I think they have also been rigorously assessed by other regulatory authorities of different countries, such as the US, such as the European Medicines Agency. So the vaccine has actually, safety and efficacy data has been looked at by different other regulatory authorities. But when it comes to the risk communication strategy, I think the risk communication strategy really has to be local. The community has to be involved. It also depends on the local epidemiology. Who are you targeting? For example, are you targeting sex workers? In which case, the way you communicate, the way you do risk communication would be different. Also the key actors which you're going to put into play, the other programs within the country, such as the HIV program, such as capitalizing on existing risk communication strategies that target STIs would be critical. Or are you targeting, children, if that's the highest group affected? So all that needs to be contextualized. And of course, vaccine hesitancy actually exists in a continuum. You also have to understand what is the risk perception of the community towards the disease. In some communities, maybe, they have seen so many cases of the disease, and they have a lower risk perception to the disease. But in other communities, that may not be the case. I think in the global response, there was actually quite a good uptake of the vaccine in the men who have sex with men communities in some of these developed countries. But maybe that may not be, the same in African settings where you're having the disease, where the disease is endemic. Most of people already know about the disease, but where we are seeing maybe a higher incidence and we need to do a public health response. That's just in a nutshell to say risk communication is very important, but no matter what we plan to do, we have to contextualize. We have to understand what's the local perception about the disease and how receptive the communities would be towards vaccination. And it's also worth noting that some of the vaccination procedures, such as using the bifurcated needle, that may be different from other from other vaccination strategies which the community is used to, and that has to be clearly communicated. So it's really, understanding the local epidemiology, defining the target population, and working with risk communication colleagues to know how best to tailor risk communication measures to ensure the uptake of the vaccine among the targeted groups to be vaccinated. Thanks. Maybe Rosemont can throw a bit more light as well. Thanks.
Okay, thank you very much, Brian. Rosemont, are you with us?
I still am. I think you've covered it all, though, with respect to risk communications and vaccines, pointing out as you did that there are different types of vaccines that could be accessed through donations as well as procurement is something else to consider. And they will have different considerations.
Okay, thank you very much, Rosemont, and all panelists. I remember in 1988, I think I presented that one, Rosemont, already, and still have those questions. First question was, what is the epidemic potential of monkeypox in unvaccinated human population? The second question was, is it possible that monkeypox could persist in unvaccinated human population through continuous person-to-person transmission? You can see from 1970 to now, 2024, we know now a lot of information about mpox, and we don't know more as well as we go, because we need to finish the disease to stop the transmission with the available knowledge. Then this is really the work of everyone, analysts, including participants. If you are on this platform today, because you care about mpox, because you care about other diseases, because you care about human well-being and health. So thank you very much for really to attend this, for attending this webinar and this series. And we gain from you a lot of experience, a lot of knowledge, and we still have to face the reality, to work together and to tackle this disease and other as well. Thank you very much. I think, Mohamed, we need to send a special thanks to all the panelists and participants as well when you share the presentation. And it will be in a PDF format, and you will have the record as well. And so these are very important. And some questions still there, Rosamond. I think these need to be compiled and shared. So I gave you the floor. You, the technical lead, Rosamond, take the floor and close the meeting now, please. Thank you.
Well, merci à tous, and thank you especially to our esteemed panelists who've given their time to prepare the presentations and the time to deliver them and answer your questions. And thank you all for your participation in this important topic. We're always here for you to answer your questions if we can, but more likely to find the answers together. I think that's the more likely outcome in this emerging disease. And so thanks and good luck to you all.
Okay, thanks.
Of course. And all the team who pulled this together.
Thank you very much. Thank you.